Nomis. I see some familiar names. Hi, Larry. Bunch of you guys that have been around like me for a long time. I was diagnosed 1 year after I got to the States. I moved from Venezuela to move with my boyfriend back then, and then a year later he tested behind my back. Back then, as you remember, we didn't have any treatment, so most of us didn't care about getting tested because there was nothing we could do about it except get high anxiety. But anyways, so I found out in 85, around 85 and a half, when the test came out that I was positive, and as you all here know. I usually talk to people that have no HIV diagnosis, so it's a little different. But now all of you long-term survivors know what we go through. The interesting thing is I'm a chemical engineer, worked for oil and gas for a while, but then completely got obsessed with surviving, like all of us, preventing wasting syndrome. And well, many of us were scared to die in bones, like most of our friends and lovers and boyfriends and girlfriends. And became obsessed with not losing lean body mass, which was the number one or number two cause of death back in the 80s and 90s. And that's when then my whole hormone educational path started to the point that I'm still doing kind of a hormone education, but not so much on the HIV, on the HIV field, but mostly on just general men's health and women's health. So I've been able to learn a lot from our struggle in HIV. Next slide. I think these are probably the old slides. Oh no, I said they're good. They're new slides. I sent some slides yesterday. I keep changing my mind. But anyways, this is this slide that you see there, the word challenging and all the other words actually came from a survey that was done over 1,000 people every year. They do it every year, HIV Academy. And they find that most of us are having a very hard time growing old. We're all of us, I'm sure most of us are happy to be here this long. I'm counting over 40 years now and being around. Well, most of us had to bury friends and lovers and family members. But the fact is it's been challenging. Why? Because we see more and more data that a lot of our symptoms of aging are happening earlier than the general population. Some of us have either two or more comorbidities, high blood pressure, visceral fat accumulation, depression, or mental health issues, digestive problems, etc. I mean, we can count them. So we are multi comorbidity. They call us polypharmacy patients because we're taking more than two or three or five meds, including the HIV meds. And 64% of the respondents in the survey also reported mental health concerns like depression. But also fatigue, body aches. 64% said they had body aches daily. I'm one of them, and feeling tired. But feeling tired could be caused not only by HIV, by the fact that obviously we're going through aging with a chronic illness, but also about um, having low hormones. So I'm going to talk about hormones today. Next slide, please. And what is successful aging, especially in view of having infectious disease that is has chronic inflammation as one of its factors. But successful aging is to age. We're all gonna age and die eventually, hopefully of suddenly. I'd like to die suddenly, meaning I'm lucky ones that die while they're asleep or but not suffer so much or having people take care of me. That's my biggest concern. I don't want to have family members or have to take care of me or my husband, for instance. I just want to be able to die without too much disability. Okay. So they call it disability-free longevity. That's what they call it in the anti-aging world that I work with. Accelerated aging, as some of you have seen in previous lectures with other speakers, they're showing that we are aging around 10 to 15 years faster than our HIV negative cohort or controls. And so what do we do about it? We do have HIV. So most of us are lucky enough to have undetectable viral load. I'm one of them that had to spent 25 years with multi-drug resistance and finally got to that undetectable number. But there are other issues that keep happening with chronic inflammation, sarcopenia, there's some frailty. Even though we are not wasting like we used to in the 80s and 90s, we are losing lean body mass while we're aging. And sometimes we're also experiencing bone loss and fractures. So how do we do that? One of the next slide, please. One of the main factors is the measuring our hormones, especially testosterone. I'm going to be focusing a lot today on testosterone. That's really, I've written 3 books. I think I've become pretty much knowledgeable, not only because of me, but also run a site called excelmale.com. There are over 45,000 men from all over the world sharing experiences every single day for the last 14 years. So I've learned a lot from them too. But in HIV, what we have is that 1 in 3 of us is living, have TD, testosterone deficiency, and nearly triple the rate of people or men without HIV. When it comes to women with HIV, up to 50% are now having what we call low free testosterone. So I'm going to talk about the total testosterone, free testosterone. What's the difference? How to talk to your doctor. Really, what I want to walk away from today is give you enough information so that you know your options. You know how to ask for a blood test. What kind of blood test? Because there are different types of blood tests for testosterone. And a lot of doctors are using the old method, the old assays that are not as accurate. Next slide, please. So the symptoms, and you probably heard this a lot. I mean, testosterone clinics are popping up like Starbucks, everywhere. You probably have gotten hit several times a day on Facebook, on Instagram, with ads from these clinics, telemedicine especially. There has been a boom. Okay, there is in the United States. By the way, I'm in Portugal. I moved to Portugal. Here is a different world. Testosterone is like a bad word. Like we used to stigmatize testosterone 25 years ago in the States. Here, the doctors are telling me you need to stop taking testosterone. Imagine somebody like me taking testosterone for 35 years, a doctor that is not informed. But in the States, we have a lot of doctors that are now educated compared to just even 10 years ago, because this is not only become high awareness issue, but also a business. Telemedicine is usually cash-based, no insurance. They don't take insurance. There are over 1,500 telemedicine companies. COVID exploded the telemedicine industry because obviously we were all, indoors and we needed to get access to healthcare. So the government kind of relaxed the rules about telemedicine. So now, and expanded the rules. So now we still have freedom of telemedicine. Most countries don't have that freedom. But anyways, so more and more testosterone information coming through you. And the main effects that I usually talk about is low sex drive. Low sex drive is one of the symptoms, but not the only one. Actually, brain fog, they call it, unexplained depression, severe fatigue. You're losing muscle or weight, even though you're trying to go to the gym and doing your best. Insulin resistance, bone loss. Some of us have never gotten tested for bone density, which is another issue I'm going to talk about. So these are different, and most of us may have more than one symptom. Back in the days, back when I got my first shot of testosterone in 92 or so, I did not get tested for any of this because I was losing weight and my friends were losing weight and muscle. And we said, screw it, we're going to go on this hormones, on not on testosterone. We started using nandrolone and oxandrolone, which are FDA approved anabolic steroids that I wrote a book about. But we didn't have what we have now, which is the blood testing, the symptom analysis. We were desperate for avoiding lean body mass loss. Next slide, please. So basically, HIV drained your. Why do we have more testosterone deficiency in HIV? We have not only that visceral fat that has an effect on it, we also have inflammatory. The virus itself, even though it's undetectable, it still produces, our cells produce inflammatory biomarkers. There's a brain hormone disconnect with the testicles. Some of us may have to take medications like opiates or painkillers that also can affect blood levels. Next one, I think these are the old slides, not the ones I sent yesterday, Heather. Unfortunately, these are the basic slides. I'm gonna go basic today. I have more detailed slides that I sent yesterday to the group, but I think she got the one I sent a week ago. I'm gonna go basic. This is gonna be my basic slide, and then we'll deal with the complexities in questions. So this is a diagnostic trap, I call. What do you talk when you talk to your doctor about getting tested if you're not on testosterone? Many doctors in HIV are educated about testosterone. Why? Because data was very strong in the 90s saying, hey, these patients are having low testosterone, low thyroid, sometimes they're wasting away, and the HIV docs that some of them are retired, unfortunately, but they were the first ones that prescribed not only testosterone and nandrolone. So there's a lot more awareness. However, if you are accessing Ryan White clinics, or that may not be the case, especially with doctors that have not ever worked with HIV before. But you need to, when you talk to your doctor, not only talk about the symptoms, if you're fatigued, if you really sex drive is not even there. Some people have completely given up on sex for many years just because there was no interest in sex. And there's nothing wrong with that as long as it's your personal choice, not your body basically telling you or your mind not telling you that you just don't have any interest whatsoever. Some men stop even masturbating or even they basically have no interest whatsoever. Fatigue, loss of lean body mass. You go to the doctor and you say, doctor, I'm wondering, so you do have to be very careful how you phrase this. I'm wondering if I may have low testosterone. The doctor, he or she may say, why? You say the symptoms. And then when the doctor and ask for a test, can I get a blood test done? You ask for not only total testosterone, but free. I'm going to explain what free testosterone is. It's the active part of testosterone. It's only 2% of the total. And it's also, until recently, until maybe 4 years ago, it was tested. No, it was not even tested. It was done by a calculation, which was usually 20% inaccurate. So now we have actually testing assays for free testosterone. So total and free. Get it tested in the morning before breakfast because breakfast or any food can actually temporarily lower your testosterone by 20 or 30%. So it's good to have a real number and get tested more than one time, like 2 nights, 2 mornings in a row before having breakfast. And also ask for something called sex hormone binding globulin if your doctor is willing to write that order. Something else that most people with HIV don't know is that even without a prescription, you can get your own blood test financially affordably. Like the testosterone, I used to have a company called Discounted Labs that I sold last year because I was retiring that sold the whole panel for $40. So you can actually take charge and get tested with discountedlabs.com or privatemdlabs.com, or there are probably 10 companies online that you can actually order your blood test from. Some of them are more expensive than the others. So hopefully your doctor will write it up so that your insurance can pay for, or your assistance program can pay for your lab test. That's number one. Without a diagnosis or without a lab test, usually you're not going to get insurance companies to pay for the treatment that you may need. Next slide, please. And with women with HIV and women in general are having a very difficult time convincing their doctors that they need to get their testosterone checked. Believe it or not, most doctors are not educated on the fact that women have testosterone. It's 10% of what men have, and they need it for the same reasons we need it, to keep lean body mass on, to keep bone density, to keep mood, sexual function, sexual drive. And that's being a hard thing. Even now, I do lectures for women that are not obviously HIV positive, and they're having issues. Another problem for women in general is that there is not an FDA approved testosterone replacement product for them. So all the testosterone products that women are using now are considered off-label. Most of women are getting it from compounding pharmacies. That's something else that unfortunately we don't have enough education in HIV. The fact that there are pharmacies like pharmaceutical companies, but they're smaller and they actually can make a lower cost, customized treatments for men and women, not only women, but women in particular, because insurance companies don't want to pay for testosterone treatment for women because the FDA has not approved a product yet, believe it or not. Europe has approved, a few countries in Europe, and Canada and Australia have approved products, but not the FDA. Next slide, please. And the treatments have evolved. I mean, testosterone, the injectable testosterone, cypionate and nphate, were around 50 years ago. They're very cheap products. They're in, I wouldn't say the number one prescriptions for testosterone. I think testosterone gels, creams and gels are more commonly prescribed. I think gels and creams are a good way to start if you really want to start treatment because you need it. I'm going to talk about what that means, what the levels should be. But they have gone from injections. We have in the early 2000s, we started getting the androgels and the test stems, and there's one that you put under the armpit, et cetera, et cetera. So they're gels. And now lately, we've had orals. We used to have an oral back in 40 years ago that was liver toxic. Now the new orals oral testosterone are not liver toxic whatsoever. They actually bypass the liver. So products are evolving. They're getting friendlier. They're getting different types of administration. Next one, please. So they're auto injectors now, as I said, oral pills. There is testosterone and lecanoate, and they're pellets also. I'm not a friend of pellets. Pellets are put in under the skin. You have to pay cash. It's a lot of money. And you cannot titrate your dose, meaning doctors cannot change your dose with orals or injections or gels, depending on your blood levels, because doctors check your blood levels again 6 to 8 weeks after you start. But pellets last 3 months. So there is no such a thing as an adjustment within the first 3 months. And they're also expensive. Some people like it, pilots, people that are always on the move, that they have the money, obviously, like pellets, but I'm not a friend of them. Next one, please. So, and now we're going to talk about the fears. The first fear was, is testosterone going to increase my chances to get prostate cancer? There are many studies now that have proven the opposite. Is men with low testosterone may have higher risk of more aggressive prostate cancer. And testosterone itself, the replacement of testosterone does not increase prostate cancer incidence. However, if you have active prostate cancer, it may actually make it worse at the beginning of the treatment, meaning your PSA may shoot up. So it is safe for the heart. It is safe for the prostate. The heart data we just got in 2023, paid by the government, a large study, a long-term study of 5,000, 5,200 men that showed no increases in heart and cardiovascular risk and strokes. With a caveat, this was done with androgel, with a gel, not with injections. And I talk a little bit about how injections, most of my guys on Excel Mail love injections. They don't want to do gels. They want to be able to control the dose more readily and actually probably even get more muscle, more energy, because with injections you can even go a little higher than the gels. So we'll talk a little bit about that. But it is safe for the heart if you're using gels. Injections, you're going to have to monitor red blood cells. I'll show you guys what I mean. And when it comes to the prostate, it does not cause prostate cancer. It can worsen it if you have it. So doctors always check for PSA before you start treatment, just to make sure your PSA is below 4, 3.5 or 4. Next slide, please. So not only and to jump, if you have low testosterone, to jump for treatment right away may not be the smartest thing to do. depending on what your levels are. Some insurance companies, unfortunately, I don't have the slide here because I sent a clinical slides yesterday, but we're doing the basic one. Insurance companies don't want to pay for treatments if your testosterone is over 350 nanograms per deciliter. That's the American kind of standard. Some clinical and guidelines groups don't agree with that. They think 400. Most telemedicine companies treat you even if you have 400, 450, if you have all the symptoms. However, if you don't want to try testosterone injections or gels or pellets or nasal sprays or you name it, I'm going to show you the slide where all the treatments are. You may actually look into if you're overweight, losing weight can increase your testosterone by 15, 20%. If you're not sleeping well, that can decrease your testosterone easily, 15, 20%. So sleeping better, losing weight, obviously, if you're overweight, decreasing your stress, that's easier said than done. Things of that nature. Getting enough vitamin D, enough sun. But you should expect only an increase of around 20% or so, maximum 30% if you really are overweight. What does that mean? If you had 300 nanograms, it would probably go up to, 400, 450, 500, good enough to feel better. But if you're really low, like 200 nanograms, and some men have gone as low as like 50 nanograms, the natural approach is not going to get you to levels where you're going to feel a difference. Okay, so I wanted to say that. Resistance exercise increases also testosterone by 15% or so. Decreasing belly fat. We have dealt with lipodystrophy. We know how hard it's been. I mean, it's getting rid of visceral fat, the fat that is inside the organ cavity, has never been easy in HIV. In fact, we only have one product approved, Agrifta, super expensive. You have to inject every day. Yes, your visceral fat, your waist size decreases by 1 inch, but if you stop taking it, it'll go up again. Now we have GLP-1s, which is semaglutide, tirzepatide. Those drugs are amazing. People are losing dramatic amounts of weight. However, we have to be very careful because we don't want to go the other way, which is wasting away, like you see some celebrities on TV and movies actually now being they're becoming skeletons. So because of the abuse of GLP-1s. And I'm not going to talk much about that because that's another complete different lecture. Next one, please. And I'm sorry that I'm jumping around, but this is so basic sometimes that I feel like I'm not serving you guys as well as I could. But anyways, let's just make the best out of it. So if you your next door doctor's appointment, if you're not on testosterone, you you talk about symptoms first. Because I have HIV. I've seen somewhere where sex hormone binding globulin, that's a hormone that grabs on testosterone and it does not let it do its job. The body controls testosterone. The body doesn't want to have your cells exposed to too much testosterone because side effects could occur. So the body is a very smart thing, but some of us overproduce sex hormone binding globulin because of inflammation. And that leaves very little testosterone, free testosterone to do the job it needs to be doing. Need to get tested between 7 a.m. and 10 before breakfast. And then you talk to a doctor about treatments. And some doctors already have their mindset on what they want to do, what they want to use. What I've seen a lot, if you have insurance, some insurance companies will approve some options and others because they already have deals going on with the pharmaceutical companies for discounts on certain products. Even though you may qualify for all of them, they actually determine what you actually need, which should be the job of your doctor, not of insurance. Next one, please. So these are just resources. I have my nonprofit called Program for Wellness Restoration. I have a few books on Amazon. I sent a free PDF, a booklet of 50 pages to the reunion project to send everybody on that is watching right now. You guys are going to get a free condensed version of the latest data for everybody for free today, hopefully. And my website for men's health, excelmail.com, is a forum. And next one, I think if this is it, yeah, yeah, it's a lot shorter than my other present. So we have a lot more time for questions because I really wanted to spend like 45 minutes to an hour, but we have 40 minutes. So we have a lot of time for questions. I really want everybody to keep asking me about side effects. If you're already on testosterone, ask me questions about side effects. If you have any questions, if you have any fears, testing, et cetera, et cetera. So Joseph, who is managing the, okay, there you go. There you go. Hi,
Hey.
Joseph.
Hi. Um, you mentioned about a PSA test, which tests your potential for prostate cancer. But I think my HIV doctor told me that that test can be a little bit dangerous.
No, it's deceiving, deceiving. I mean,
Oh.
we used to overtest for PSA because there are many reasons that your PSA may be high, not only cancer, right? They're like most of us don't know, and it's happened to me. I
Mhm.
don't, I never had prostate cancer, but it's gone up, and it's gone up to like 4.5. Eh, Especially in testosterone, there is a contraindication. If your PSA is over 4, you're not gonna get testosterone until the doctor finds out, or the andrology or the urologist, why it's high. And prostatic infections, prostatitis could be a cause, has nothing to do with cancer. So doctors retest. They may actually, if you're still high, 5, 6, 7, they may send you to urologist for MRI, for an actual MRI of a prostate to see whether there's something going on there. But PSA, no, PSA is still useful just to find out if you're close to that 4. If you're close to that 4, every doctor should test every man for PSA before starting testosterone because it's part of the guidelines. By you should never give testosterone to any man with a 4 or above, or anything close to a 4 in PSA. And then obviously investigate and hopefully bring them down. Antibiotics, if you have prostatic inflammation due to prostatitis, can bring the PSA down again to, from 5 or 6 to 2.5 and be you're within range. So PSA is not useless. It was used before, and I think a lot of men that had very early stages of cancer of prostatic cancer were aggressively treated, and obviously prostate cancer, especially removal of prostate, has issues like urinary uh, retention. You basically, or you sexual dysfunction, erectile dysfunction, um, a lot of issues with overdiagnosing and overtreating prostatic cancer. Some doctors now, if you're old enough, like I am at 67, some doctors may say we'll keep you at close monitoring every 6 months, and we're not going to treat you because some prostate cancer is very slow moving. Some of us may live to 85 if we're lucky. I don't even know how some of us can make it to this old age. So it's a very different world when it comes to prostate cancer. I work with a lot of urologists that are very conservative now and not over treating and over testing prostate cancer with PSA. Any other question? I'm sorry, Joseph, did I answer your
Yeah, thank you.
question?
Hi, Nelson. I just wanted to let you know that I have access to that other slide deck. If there's anything in particular that you'd like me to show and highlight, we can absolutely do that. But the
Yes.
chat
You
is
put it,
also
you put it
flooded.
back on, and because I have some good pictures there, I have some
Yeah, of
treatment.
course. Yeah, would you
Yeah.
like me to share that for you?
And I apologize. Yeah, please.
Yeah, no
You
worries at
want me to
all.
do it, or do you want me to do it
Yeah,
from
why
here?
don't you do it?
Yeah.
You have access to because you know exactly where you want to go, and
Okay.
we'll let
Let
you
me
know there
share.
are
Let
so
me share
many
my screen.
questions.
Hey guys, I apologize for this, but it's not anybody's fault. But I keep uh I keep changing things, and
That is
hopefully
okay. We go with the flow here, and we want to make sure everyone gets the information.
is
Uh,
everybody able to see my screen? Yes, no?
yeah,
Yes.
we can.
Okay, okay. So I'm gonna go really fast because I know exactly which uh, which slides.
And while you're doing that, I'm just gonna take a look through the chat and start like picking out questions because I
Yeah,
see you all
please,
there. There's so
please.
much conversation and so much interest in this topic. So thanks again, Nelson.
Yes, please. Appreciate your helping me. So okay, let's do this because I was talking about contraindications. What is contraindications? These are things that if you have them, you cannot get testosterone. Okay, so obviously, if you have breast or untreated prostate cancer, obviously, like I said before, hematocrit. I'm going to speak about hematocrit is a proportion of red blood cells in your blood. Testosterone, androgens in general, is good when you're anemic because your bone marrow is overactive with testosterone, starts producing red blood cells. And that's good if you have low red blood cells. But if you have normal red blood cells, having too many red blood cells can increase viscosity. So your blood becomes thicker and your heart is a pump. Pumps don't like very thick, sludgy liquid. So um, high hematocrit, if you already have it, and why would you have high hematocrit without testosterone if you have sleep apnea? I believe, and this is my opinion, that sleep apnea is the most unresearched, unstudied issue in HIV. I think a lot of us, even overweight, not overweight, because there are two types of sleep apnea. If you're overweight, your neck size is big, you're snoring a lot at night, that's obstructive sleep apnea. What happens with sleep apnea? You're basically starving your body of oxygen at night. You're grasping for air. If you're waking up in sweats, if you're waking up all of a sudden like you have this feeling that you're falling, or if you have obviously somebody sleeping with you and telling you that you stop, breathing, you have sleep apnea, and you should get tested for sleep apnea. Fatigue, sexual dysfunction, high blood pressure, all those symptoms that are the symptoms of low testosterone are also symptoms of sleep apnea. And a man with sleep apnea should not be given treatment, testosterone treatment, because it's going to make testosterone also makes sleep apnea worse, and red blood cells are going to go up even more. So it's not a good thing. So that is, I wish we push for more data on that because a lot of us are fatigued and we think it's all about the hormones, and we do not have a doctor that sends us to a sleep center. Sleep studies are not fun. They're not. They send you to a clinic, they hook you up, put all this gummy stuff. I've done it on your brain. But now they have home-based testing. They say it's not as accurate, but insurance companies pay for it, where you basically sleep in your own bed. You don't have anything hooked up. They hook you up your fingers. There's an oxygen meter on your finger, and that's what's being used lately. And I think it's friendlier, may not be as accurate, but I was not able to sleep in the clinic setting because there were too many wires and somebody watching you all night. That was not fun. But having said that, if you have sleep apnea, the CPAPs, the basically air pumps, my husband has one. I tried one that had very mild sleep apnea. I could not do it. It's very claustrophobic. But look at it because some people, my husband for sure, his life's changed. And obviously, he got tested for testosterone after. Yes, he still had low testosterone, so they put him on testosterone, and he's getting the CPAP. LUTS, meaning lower urinary tract symptoms. If you're having issues voiding or always feeling like you have to pee and you really go to the bathroom and you're just dribbling, which is also an age issue, and nobody has checked your prostatic size by digital rectal exam or MRI, then it may get worse with testosterone. So it's always good to have, especially at our age, if you're not getting at least your digital rectal exam at least once every 2 years, depending on how you're doing, you should, because that also is a contraindication. If you have congestive heart failure or have had it, and that's obviously obvious. When you cannot, you're out of breath. You having congestive heart failure is an obvious thing. Nobody's gonna just assume it's something else, and you end up in the ER. And obviously, may not be an issue for us, but if you want to have kids, testosterone shuts down your sperm production. Although I say nuance, you can add on another product called HCG or clomiphene that allows you to use testosterone and produce sperm for fertility. So these are, I always, I've been saying all the good things about testosterone treatment, we have low testosterone. These are the things that um, every doctor should know, really. So let me go. Okay, so these are pictures. Let me see if so, like I said before, the 1935, 37, that's when the first testosterone was first synthesized. And the injections since 1979, patches that no longer are used because they were not as effective. Androgel, which is the gel that really picked everything up. That's 2000, and now there are bunches. And there is a nasal gel. I've used all these products, by the way, just because I had to write a book. This is a little tricky. It increases your testosterone real quick. You have to do it 2 or 3 times a day. Who's going to do that? This is an auto injector for those that are afraid of injecting. So this thing actually, you don't see the needle. And the last one's obviously the orals, which are good. I I tried them, but I have to say I take too many pills, and they're huge. They're big horse pills, twice a day with food. There's the one you see here on the underarm lotion, because what happened with testosterone gels and creams is that especially straight men that have kids or having sex with a female, they were transferring by contact testosterone to their sexual partners or their kids. So the FDA sent a warning to all the gel companies, and this company got smart and said, "Oh, we're going to do an underarm lotion." And let me see, show something because I like this picture so you guys can see the options. There's a long-acting injection that you can inject. You inject is a big injection, 3 cc's, oil-based, and then every 10 weeks you get an injection. It is approved in the United States, but many doctors don't prescribe it because the company requires the doctors to be trained, and the FDA really put a lot of restrictions on Avid, and some insurance companies don't like to pay for it. This is the gel, which, as I said, is not very popular. These are the different orals, Jatenso, Kisotrex, and Cleando. Kisotrex is probably the best sold. And what most men or women don't know is that all these products and also most of them can be made by compounding pharmacies. So what happens? I see it a lot when people say, Nelson, I got tested, my testosterone is low, but my insurance company does not want to pay for the products. So I tell them at least try to get your doctor to fax the prescription to a compounding pharmacy. I work a lot with Empower Pharmacy because it's the biggest in the States, and it's also in Houston where I used to live. But they make creams, they make injectables, they make orals, they make HCG, they make pellets and clomiphene. So that's something that I think we need more education about, the fact that not only big pharma, but smaller. And these are just a table I put together. By the way, you guys are going to get this slide set sent because I send it as a PDF with treatments, dosing, etc. I don't want to really go into that. Something else that has changed, and this is dramatic. This is dramatic. We used to, in HIV, for the longest time, since 92, I've been taking testosterone until probably 2010. We're injecting in the glute with a big 1.5 inch syringe. And then we started getting data from trans men, studies done in trans men that were put on testosterone, but using subcutaneous under the skin, smaller injections with an insulin syringe, and their levels were amazing. So that's when, because doctors used to say, oh, only deep tissue, deep injections work. And in fact, it's now we are all, I'm one of them. I'm using insulin syringe twice a week, very low doses on my shoulders or on the skin. I don't like under skin because I have some redness and bumpiness there. So that's something that really has changed. And I have to say, most telemedicine companies are doing it. This was then this big, you have to like put a loading syringe, then and then you have to aspirate. Now we use a very tiny syringe and a lot lower doses because we're not really into this. We're not really doing this for bodybuilding. We're doing this for health. So basically, you see the oil is put in the intramuscularly or on the subcutaneous or fat tissue, and the absorption is the same. So the issue is, so I said before, no cancer, no prostate cancer, no liver toxicity, and no heart attacks. But the fact is that we have to really look at this. These are the things that really make injections being a little less friendly than the gels. The fact that injections tend to increase testosterone, red blood cells more dramatically than creams, gels, and all the other. These are the risk matrix is called. The higher risk of high red blood cell production are injections, pellets, transdermal gels are lower. The orals are very low, and the gels are low too. So nobody tells you this. Even doctors, and I lecture a lot to doctors that are not aware of hematocrit. So hematocrit, if it's high, your red blood cells are high, the first thing to do is to send you to a blood center to donate blood. We cannot donate, although I think that was changed recently. But we can have the doctor write a script for therapeutic phlebotomy, which is basically letting some. They don't use our blood because of HIV, and they don't like blood that is high hematocrit for donations. So, but they dispose of them. And I'm gonna go through this. This is yeah. The too many frequent donations, blood donations, decrease your iron, and you may become very tired. So that's something else I had to educate my guys on Excel Mail. Their blood testing that needs to be done at the beginning, and then every 6 to 8 months. The first year is the most critical. After the first year, everything stabilizes, and um, the monitoring doesn't is not as strict anymore because you're like me. I don't get my testosterone tested anymore because I know the dose, I know how much I need, and my hematocrit is stable. I haven't donated blood in maybe 20 years. Um, my nonprofit, I have a group called Post Health that is long timers. I created it in 2002, and there's probably 1,800 of us, long-term survivors. And this is where the really smart guys are, Jules Levin, Jeff Taylor, and a lot of the guys that go to all the conferences post there. Um, Post Health is my Facebook group, excelmail.com for men's health. For telemedicine, this is the longest acting telemedicine company. My best friend owns it. It has an HIV discount program for those that don't have access. Empower Pharmacy, this used to be my company, Discounted Labs. I used to sell blood tests without needing a doctor's order. I have maybe a 42,000 women's group on Facebook called Women's Health and HRT for women to discuss anything related to HRT, hormones, menopause, et cetera, et cetera. And yeah, we'll stop there, I think. And as I said, you guys are gonna get um, a handout. And let me stop sharing. There you go. Let me stop sharing. Let me just stop sharing. Sorry, guys. Let me just get out of this mode. So,
I
did I stop
gotcha.
sharing? Yes.
Yeah,
Okay.
you sure
All
did.
right. Sorry about that. Now we
No
can
worries.
go back to questions. Sorry.
Thank you. And I
Thank you.
just want to say, I think the basic slide deck was so good to like lead us into the topic. And
I
then,
think so.
yeah, that was wonderful. Thank you so
You're
much.
welcome.
Also, very interested in that Facebook group you have. I will be joining. Thank you, Nelson. Would we let's go ahead and look in the chat. There's so many questions.
Yeah.
So
Oh, I'm so sorry. Let's
yeah,
see.
yeah. No, no, no. That's okay. It's great. We love this. It's obviously just showing that people are very interested and we need to know more. So, the first question that I'm seeing is from David. Are there any recommendations on those on HIV medication for a for a long time to take B12 or D3 supplements? And that's specifically to help with fatigue, chronic fatigue.
Mhm. I use, I still inject B12 once in a while. B12 is very difficult, very hard to be deficient in B12, okay? If you eat any fruits and vegetables, you'll get enough B12, okay? Yes, there is not been proven to increase energy levels in fatigue, but I do have to say anecdotally, I think it does. It's water-based. It leaves your system within a day. I feel within the first day more hunger and a little more better mood. But unfortunately, it's water-based and is it leaves your body. So you would have to inject, but orally you can absorb it too. But as I said, if you eat enough vegetables and fruit, vitamin D, most of us don't get enough sun. We were told that obviously we get more incidence of skin cancer. So I do. I think everybody should at least take 5,000 units, get your blood tested once in a while for vitamin D, because vitamin D is the only second hormone. Vitamin D is actually a hormone. It really has influences different hormonal systems. So it's and we're deficient. Most of us are. Uh, African Americans are more deficient. The darker your skin, you're more deficient. The heavier you are, you become more deficient. Very few of us are getting. You have to get at least 20 minutes of exposure on your skin. You can protect your face, obviously, in your head, but you can at least get it on your arms and legs. But as I said, the whiter you are, the more chances you can, or even brown people too, can get skin cancer. So I take 5,000. Some people need 10,000 because you actually do a blood test. And if you're not within like 30 to 60 nanograms, you are deficient. So yeah, vitamin D for sure. Like B12, it won't harm you, but it's water-based and you can eat fruits and vegetables. And the next question, hit me up. I really want to answer as many as I can.
Yeah, so feel free to raise your hand to come off mute and ask a question as well. A follow-up question that was asked in the chat in regards to what you just shared. Along with that, they are seeing things about needing to take vitamin K and D3 for proper absorption, but also to avoid it from building up detrimentally in other tissues. So they were asking, is that a true statement, or do you know anything? Can you add anything to that?
Today's talk is about hormones, about testosterone. I'm not here to talk about vitamins. That's a very complex issue because there's so much contradictory information. Many of my guys, and I say my guys, my audience on Excel Mail definitely take the two. Usually they buy it on Amazon a combo of K and D because there is synergistic effects, definitely. I don't take K. Then you have to be careful with K because it can affect clotting factors, and some of us may don't want to bleed too much if we have an accident or something else. So I don't take K. But many of the audience they swear that the combination is not only synergistic, it actually has better benefits. I don't take it. I'm really afraid of disrupting my blood clotting. Yeah.
Hi, Steve.
Somebody
Yeah,
Steve has his hand.
we have a hand up.
That's me.
Hi, Steve.
Hey, um, I care for my mother who's 88 years with dementia. And my father also had dementia. And my question is about the red blood cells. And when you take, well, there is evident one of the form of dementia is HIV related dementia. Um, this the when you take hormones and you have more production of red blood cells, it generates more oxygen to your brain and it takes the carbon dioxide to your lungs and then you get rid of it. But what about um dementia and people with HIV? I know it's a topic that we don't talk about much, but as we get older, um with HIV, what is the impact of HIV and if there is any study being done about dementia, HIV related dementia?
Not on hormones, not at all. My mother has Alzheimer's. She's 89. Obviously, anybody with parents or families that members that are close to you that have Alzheimer's, as we get older, we keep hearing about um, HIV related cognitive dysfunction. So when I forget things, I wonder if if I'm gonna, end up like my mom. All of us. I think there's not a long-term survivor that doesn't at least think about the cognitive dysfunction when is this age or is this AIDS? You know? I'm stuck in words a lot. Is this age or is this is this how does this compare to an HIV negative person healthy? We don't have data, which is, and I think we worry so much. There's no data on hormones, especially testosterone, and dementia or Alzheimer's incidence. Most geriatric doctors or neurologists, which I've taken my mom to, are opposed to any hormonal intervention for people that have been diagnosed with dementia or that just because there's hardly any no data whatsoever. So they're afraid and they get very concerned about potential vascular side effects. There's dementia that is related to vascular issues, meaning you're not getting enough oxygen to your brain. There is very strong data, very strong on cardiovascular exercise that increases your blood flow to your brain, walking fast, brisk walking is more important than any other type of exercise to oxygenate your brain. I'm very aware of that because I follow the Alzheimer's research very closely for obvious reasons. There are treatments out for Alzheimer's. They're not very effective. Their IVs are super expensive. They cause inflammation of the brain in 20% of the cases, which is not very good. But we are heading, there is a strong pipeline of oral agents that if we do have it at early stages, we can take it once a week. I'm following that closely because the Alzheimer's pipeline reminds me a lot of the HIV pipeline in the mid 90s. That's where we are. But no, to answer your question or not answer your question, I'm not really answering your question, is that we have no data on red blood cells or testosterone or HRT for women. In HRT for women, we're starting to get data on postmenopausal women, cognitive dysfunction, and improving their hormone, especially testosterone, estrogen, because estrogen is really being shown. Once it decreases to low levels after menopause, cognitive function really, really gets impacted. That we have good data on. So thank God the FDA has removed some of the black box warnings for women in the past 6 months for that. So I'm sorry, I'm rambling, but just to not answer your question.
Thank you very much.
Hey, Brad.
Thank you so much. Let's go ahead and we have some more hands up, but let's take a question from the chat. And then I see your hand, Billy, so we'll come to you afterwards. So this question is in regards to an individual's medical doctor through Kaiser. They took this individual off testosterone when they came under his care, stating that when they tested his testosterone, it was within normal range. And so they stopped providing him testosterone. And following that, he became very depressed when taken off for over a year. Do you have any insight or suggestions regarding
Wow,
this?
that is unfortunately so common. In fact, because I see posts easily 25 posts a day from all over the world, men, mostly men in my group, because we do have a female group, but in Facebook, where they do that. Doctors do that a lot, meaning doctors want to see if you really need testosterone by taking you off of it, but they don't retest you, and then you crash. So first of all, when that happens, and I'm thank God everybody's online right now, never allow that to happen. Never allow that to happen. If a doctor wants to do that because you just switched to a new doctor, you need to find another doctor. You are not there to educate them. There's something called the shutdown of we have, and I didn't show that slide, obviously. The hypothalamic pituitary is inside behind the nose, testicular or ovaries, because ovaries produce testosterone too. When we inject or do gels or whatever, that whole axis is shut down. The body says, oh, we got enough testosterone, no more, no signals to the testicles, shut down, go to sleep. And actually, that's one of the causes for the low sperm production and also for what we call testicular atrophy or shrinkage, which is reversible. So don't be too afraid about that. But when you stop testosterone, it takes easily 6 to 12 weeks to get to the level you were in before you started. And you started it usually because of a reason. Either the reason was you had low testosterone, you had all the symptoms, And obviously, removing testosterone from your body will put you in a real shock and depression, cognitive dysfunction. Your coping will go down. Do not ever allow that to happen. I see many guys that go like, well, if you, because, and this, you're gonna have to forgive me, and because all of you are long-term survivors, and I know what that means. Long-term survivors means we have survived the medical system. We have taken charge. We have read, we're in lectures. Sometimes we know more than our doctors. And some of us push back. Some of us are nice about it. Some of us are like me. I'm a difficult patient, they call me sometimes. But we do not just say yes, sir, or yes, ma'am, like many people that don't have the level of education or the survival. So we didn't survive only because we took our meds. We survived also because we got savvy to avoid malpractice related issues. That I consider malpractice, to stop somebody from getting testosterone. And the main reason doctors do that is because they are afraid that it's going to show in their records that they're prescribing a Schedule 3. What is a Schedule 3? A Schedule 1 is drugs that are illegal, cocaine, LSD, heroin, even psychedelics, which are now becoming trendy, are Schedule 1. You go to jail, blah, 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 although psychedelics are becoming more. But anyways, LSD, heroin, all that. Schedule 2 are the ones that have highly addictive properties. They're prescribed, but like, but morphine or things like that, you need mostly pain meds. And Schedule 3 are testosterone, some prescriptions for mostly pain, that may have supposedly addictive, although testosterone has no addictive properties. By the way, we're fighting that with the FDA, so testosterone may get descheduled to Schedule 4, which is no restrictions. But anyways, the Schedule 3s, every time a doctor prescribes a Schedule 3, they have to have a DEA number, and that prescription goes in their records. But now that testosterone is becoming less and less stigmatized, that's not as much of an issue anymore. It used to be maybe 5, 10 years ago, where doctors were like, oh, I don't prescribe that because they're afraid they're going to lose their license. That is the main reason they get you off testosterone, not because it's bad for you or because they want to see how low you can go on your own. And only unless you accept it, that will happen. But do not, because I've seen it almost every week. Somebody comes in, a new person eventually comes in and says, Nelson, he wants to see my natural production of testosterone. Well, your natural production, whatever you used to have, is not going to happen within 6 to 12 months. And sometimes it never comes back to even the baseline. So he wants to do a test to stimulate my testicles, or he wants to send me to an endocrinologist, which is the worst thing you can do. Endocrinologists are supposed to be, I'm very blunt here because you are my peers. All of you are like me. We're HIV positive. I'm not here to be uh, politically correct. Okay, I'm here to tell you what I know and what I've seen, the abuse. But endocrinologists are not the doctors that you should be seeing for testosterone. Family practice, general practitioners, urologists. Urology is a number one. Every man with HIV and aging should have a urologist. Everyone. We all have a prostate. We all have bladder issues. Eventually, we have some, issues with testicles, etc. And urologists are the number one trained. They spend 2 or 3 days in conferences studying testosterone.
Where are you?
So do not, once again, I want to do not accept that ever. If you hear a friend of yours that is suffering because of that, try to get him some help. Urology, end up in urology, never go to an endocrinologist. Endocrinologists only treat diabetes, thyroid, maybe some cortisol related issues. They're not friendly with testosterone. They're still in the old fashioned world of testosterone is going to kill you or give you prostate cancer. I'm sorry. This is very touchy for me because I've seen it so many times. And people are suffering. People suffer. Some people become suicidal, you know? So, anyways, next question. I'm so sorry.
Don't be sorry at all. Thank you so much for your honesty. That's what all of this is about. I believe, Billy, you had a question. Are you there with us, Billy? If you want to come off mute and ask that question.
Yes, I am, and thank you so much for this wonderful presentation. I j- I have two questions, but I'm going to try to make them very brief. Um, this type of environment in which we are learning all of this information is good, but if you're only doing this once, where do people have to go to learn more information about this, to get further in depth in some of the questions that are being asked? Because I know you can't ask every question,
Yeah.
today. So,
Yeah, yeah.
you know,
Thank you, Billy. No, thank you. No, I sent you guys the group. Heather's got to take care of it. I sent you. I did with AI. I took all my books, put them together on AI. Said the AI, please summarize these books, the three books, into a booklet of no more than 50 pages. So you're gonna get a PDF that you can download and hopefully you'll read it because some people don't like to read it.
oh,
But
I
it's
will read it.
basically summarized everything I said and more because obviously in an hour, this is such a expanding field. So
Exactly.
you'll be able, and in the PDF, you're gonna see my email and a way to contact me. Okay. So I usually do coaching sessions for people that are not HIV positive, but for my HIV folks, I am always available on email. I never, never not help somebody like us, because yeah, we're heroes. We're survivors. As I said, no, we are here not only because we were lucky, but because we survived malpractice.
I always say we're here because there's some unfinished business that we have to take care of.
And hopefully help the world and help others. So,
Yes. And now my other question is, I I see sometimes that people use brain fog interchangeably with, dementia. And I'm sure there's a clear definition between the two of them. There's a clear diagnosis between the two of them. Could you speak on that just briefly, please?
that's a good question. That's a good question. I have brain fog in the morning for at least 3 hours. Okay. Don't talk to me. I need my coffee. I just do. I cannot think straight. I don't want to be exposed to any stressors. Some of us are not morning people.
Morning person.
Oh my God, could be up till 1 o'clock at night, and I can give you the best answers of everything. So brain fog is that. Brain fog is feeling like you cannot really think straight, or you cannot deal with stress. You don't even we all know when we're at our peaks, meaning bring it on, like bring it on attitude. Like, okay, you're having problems. This is what I'm gonna do. You are very sharp. We know when we're sharp. Usually for me, it's around this time in the afternoon, and we know. But in the morning, we may be brain foggy. If we had a few drinks at night, which I do here in Portugal, everything is bottles of wine are 2, 3 euros. That's also brain foggy. But dementia is permanent. Dementia tends to fluctuate, but it's permanent. I've been watching my mom, and now I follow a bunch of people online on Alzheimer's. And dementia is repeating yourself to people around you about the same thing. And it happens more than once. You're repeating yourself. Somebody may tell you that. For me, if somebody is telling me, because I'm concerned about Alzheimer's and dementia. I am very much so. I'm my mom's boy. I got tested for mutations that are more indicative of potentially developing Alzheimer's. I'm negative, but that means nothing. That means a little bit of hope, but not really. We can have like lifestyle that is less conducive to dementia and anxiety. Like I said, walking, aerating your brain, increasing your exercise rate, eating more anti-inflammatory vegetables, fruits, um, managing stress, getting more socially connected, because that's probably number one or two indicator of longevity. How many people you're interacting with, not only family, friends, not online, because online I have a lot of friends, but real friends that you call and call when you're crying. Who is gonna that keeps your brain sharp. I heard there's nothing better than learning a new language. I'm trying to learn Portuguese. Not a good thing at 67, but that also opens up neurological paths. And I'm going to bring it up because that's another lecture. Maybe reunion project and bring me back from that lecture. But they use psychedelics and psychedelic therapies. We're connecting parts of the brain that have been dormant. I've done almost every psychedelic on earth with therapy, and I have to say, I wish I had known about them earlier. I'm writing a book about my experience. I think a lot of us have trauma, and trauma can actually lead to cognitive dysfunction in the long term. So there are many things that are not dementia. Brain fog is not one of them. Repeating yourself, forgetting your what you did yesterday is not dementia. Forgetting what you did your childhood completely, maybe dementia or maybe trauma. You're hiding something from your brain. So it's a neurological, you have to go to neurology. My mom spent 4 hours in a room getting tested for all kinds of cognitive tests to be diagnosed. So that's my concern. Some of us worry too much when we forget things, especially as we get older, and we think that we're going to be next. I'm one of them. I have to say I'm one of them. So anyway, sorry that I ramble so much, but
Heather, Larry and Brad have been very patient
oh no, Larry, I don't want to hear from Larry.
Oh,
waiting.
Hi,
So
Larry.
Brad
only
first
if
and
it's
then
good. No.
Larry.
How you doing?
All right, Nelson, good to see you. Um, my question is, I did actually put it in the
Chat.
whatever is the messages. I'm an old fart. I've been positive definitively for over 41 years. I think probably longer. And I'm still on testosterone, and I've been questioning somebody at my age. Should I continue? I'm kind of anxious about stopping, or should I just go by a PSA to kind of tell me when it's time to stop?
You don't stop. Don't ever stop. You're gonna die with it. Why? I'm telling you why. First of all, sometimes we don't know. We forget that testosterone made a change in our lives. We take it for granted, right? Okay, do I really need it? And then we don't find out until we get off of it. If you're a month after you stop, if you don't feel the difference, if you don't feel like you're not coping with stress as much, you're not even sleeping better, you'll know that it was doing something. It's a hard way to find out if something works, you know? So there's no long-term risk. If your PSA is fine, obviously, is if your red blood cells hematocrit is stable under 52. Mine has stabilized for many years. I'm like 49, 50. If you may say, well, I'm not getting the erections, I'm not getting the same sex drive, I'm probably developed resistance to to testosterone. There is no such a thing. Um, I'm not saying don't ever stop. It's not a life sentence. Some people stop because of side effects, but long-term users, they have found that people that have low testosterone tend to have higher risk of heart disease, heart attacks. They have higher incidence of aggressive prostate cancer, men with low testosterone. Okay, I'm not making this up. This is data. I follow the data very closely. I'm not making this up. As I said, I talk a lot about the benefits, but I'm telling you guys about the risks and the contraindications. So I'm not one of those that wants to get everybody in testosterone. I think testosterone, especially injections, are a commitment. You should not be skipping too much because you'll find the hard way that it actually was working. If you're injecting, you're probably used to the schedule. Forgetting and skipping is very common when you start asking that question to yourself. So be very careful. Catch yourself when you're forgetting more than once or twice. Is your brain trying to tell you, I don't need this anymore. I've been on it for a long time. I wonder what it is. But you're free to get off of it. And unfortunately, within 6 weeks, if you don't have any difference, then more power to you. But I haven't met anybody that has been a long-term user, especially in HIV, because we also lose lean body mass. We're losing muscle, even with
Yeah.
undetectable viral load. We have data now. Wasting, obviously, we're not wasting like we used to, but we're wasting muscle. And muscle is what keeps us functional. I tell people, if you don't work out, at least do leg exercises. Get up and down, go up the stairs, go down the stairs. Legs is what keeps us from falling and fractures. Once you fall and break your hip or your pelvis, you're out of the game. The chances of dying are dramatically increased. So, and especially us, we're all getting older, going up the stairs and down the stairs. We start hurting. The knees are issue. I just got hip replacement a year ago. I got 3 back surgeries. So we are obviously more weak, more frail, even if we work out. So there is aging is aging is not for the weak. Okay, I know HIV was a big thing to try to manage, but aging it's another challenge. And I have to say, some of us are like, God damn, I wasn't really, I'm sorry to swear, I wasn't even planning to be here at 67. You should be happy, but at the same time, there's a lot of
We're
stuff that starts
50.
occurring, and we don't know if it's age or AIDS. Okay. So, anyways, long answer for a simple question. I apologize.
Now,
Brad?
if I can just
Mhm.
interject one thing about falls and hip fractures, current thinking really is that the bones spontaneously fracture and then you fall.
Mm,
So it's not from the fall, but generally it's the result of the fracture.
mm. It's good to get a
So,
DEXA scan. Unfortunately, that's
right.
part of the guidelines. Very few of us are getting DEXA scans of the pelvis area to measure abundancy. Very few of us, and that's
Kaiser
already
is good.
yeah.
I
And
get
it's
it every 2 years. I mean, they're pretty good.
thank you,
Thanks.
Brad.
Yes, quick question. Thank you so much for your passion, especially for your mention of psychedelics and trauma healing. I have a lot of experience in that area, and I appreciate you
Oh,
speaking about it.
okay.
But on the testosterone levels and testing, SHBG is not a term I was familiar with. I'm used to seeing just regular testosterone and then the free testosterone on my testing. Is SHBG something that we should be asking for in addition to that? Or is that only if the other
Yeah,
indications come up low that we should see that?
yeah.
What is
Good,
that
good, good.
test?
Excellent question. Excellent, very clinical. Excellent question. By the way, the right codes for a LabCorp and for Quest are included in the PDF that you guys will be getting, okay? Because you have to ask for not only the test, but make sure it's the right code. I used to sell Quest and LabCorp also, so they do tend to have different ranges themselves. So sex hormone binding globulin, if your total testosterone is good, like over 500, and you feel good, you feel fine, there's no need. Free sex hormone binding globulin, the only reason they measure it or people ask for it is to be able to calculate the free testosterone because you have to subtract what's captured in sex hormone. That's the only reason. I don't ever test for sex hormone binding globulin because I'm a stable. I've been using long term. I know my dose. I know everything. But for those that have what we consider normal testosterone, I didn't even show the slide what normal is. I would say anything above 450, 500 nanograms, and have symptoms, still have symptoms, then it's very important to ask for the free testosterone, which most insurance companies don't want to pay for the fancier test, even though I sold the whole thing total free with the right testing for $42 cash. Um, so it's important for those. Is it important to get tested all the time? No. Only if you have what doctors consider normal testosterone, but you still have all the symptoms of low testosterone and you want to find out what the free testosterone is without, by calculation. It doesn't hurt. There's actually a code in Quest and LabCorp that includes total, free, and sex hormone binding globulin. And it's not that much more expensive than having just a total, which is what most doctors test. So you're gonna get the codes and the details on which test in the PDF that you will hopefully get later on today. Any other questions?
Billy has his hand up. Billy Fields.
Billy.
Yeah, I just have I have more of an observation than anything. I'm like 74 years old, and I'm noticing I've never seen so many people with walkers and having hip surgery and having knee surgery. What is going on? I've never
Good.
seen it before in my life, and I've been here for a while.
You're trying to get Nelson to be your primary care physician here.
No, 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 no. No, I know what Billy, no, I know what Billy's saying. I don't think things are changing that much. It's we are changing. I really believe as we get older, we also look around for folks that are older too. Just, I think unconsciously we're all comparing ourselves physically, like functionally, to people around. And we have friends that are our age. Most of my friends are aging with me. So we talk more about it. I mean, almost every four people that I know have a hip replacement. I'm one of them, or knee replacement. So we're also surrounded by people our age, our generation, either with or without HIV. I do think most people probably are, I think this is why I'm going to say something very kind of like my own opinion because I've learned this the hard way. My chiropractor used to say in Houston that the number one killer of Americans, besides gun violence, is sitting. We're sitting more than ever in front of computers, in front of Netflix, in front of everything. I used to sit. Houston is not a friendly walking place. And I had pain every day. Every day I had pain, back pain, hip pain. I did. I did. I was frustrated and depressed many times. I came to Portugal in vacation once or twice, and I noticed that my pain was even probably 40, 30% of what it was in Houston. So I said, is this mental, the fact that I'm on vacation? It's not. It's the fact that I'm averaging 8,000 to 10,000 steps a day here because we don't use a car here and we go shopping for food and everything else. We're like New Yorkers. New Yorkers have that kind of lifestyle. Not in Houston, you don't walk. So I remember always what he used to say. The number one reason people came to see him used to be people that used to work in construction, in labor, and then it's shifted to people that are sitting a lot. And I do believe our culture is one of sitting, especially in his cities where you have to drive. And I was a victim of that. And now I'm almost pain free. I only have pain in the morning when I wake up for an hour or two. Then I'm pain free because I'm not doing anything different. I'm drinking probably more wine than I used to, but it's really the walking. I don't have a car. So I walk. Walking, it really is important. It's just that in some parts of our country, in the United States, it's not conducive. I mean, Houston, hot and not really a walkable city. So I really, if I had to do something all over again, I would definitely try to or move away from Houston into an East Coast place. But we need to find ways to walk. We need to find ways to walk. Even go to the gym on a treadmill. We need to. Anyways, sorry. Learn. It's a lesson I just learned. Anyways. Joseph?
Yeah, let me stand up so I'm not sitting.
Just
I,
standing something.
I think I'm going to get rid of my truck and start walking around and save $1,000. I went on Facebook and I couldn't find the POZ Health.
Uh, POC Health is open. It should be a non-private, or maybe I made it private. Send me you're gonna see my Facebook. Make me a friend of yours. I'll invite you if I have a private. I also have my testosterone group. It's also private. People were complaining about they didn't want anybody, only members can see each other. Okay, so I apologize.
That's okay.
Send me a friend request because only friends can invite other friends.
Okay.
Privacy, man. I wish they were open, but they're not. I'm sorry. Somebody probably complained about being HIV positive and not wanting to be in an HIV group that everybody could see their memberships. Yeah. That's why I like excelmail.com because nobody knows who anybody is. You can call yourself whatever you want. Although some people on Facebook are doing that too now. So, anyways, any
So,
more questions? We have like, I don't know if we have any more time, but hey,
yeah, so
those.
that's the thing is like I think there are so many questions, which is wonderful. I wish we could talk forever about this, but we've actually hit time. But I want to reiterate that both slide decks, the one that Nelson started with today, as well as the longer, more intricate slide deck, are all going to be included in a follow-up email. The recording to today's session will be included. I will share all of Nelson's contact information and also sort of comb through the chat because there are so many helpful resources that have been put in the chat. And we want to keep talking about this. Like we want to keep the conversation going. Something that really stood out for me, Nelson, is, when you brought up like essentially the idea that you can fire your doctor if your doctor is not listening to you, if your doctor is not, taking into account your needs, you can find care elsewhere. And I think
Hopefully you can.
hopefully,
Hopefully, yeah.
hopefully. That's the hope. At least we can be encouraged to look elsewhere. And I just think that's so important to continue to be empowered and to empower one another. Um,
Thank you.
yeah, absolutely. But I just want to say, as a whole, thank you so much, Nelson, for being here with us today. I'm totally into a follow-up session on psychedelics and trauma. I mean, I think that's a huge conversation and it's just booming right now, the awareness around it. Um, but the questions that did go unanswered, I will include Nelson's information to reach out so that you can continue to be in contact and we can keep the conversation going. I've shared a few times in the chat and I'll do it right now, just a link to a simple evaluation for the Reunion Project in general, but also there's a more in-depth one that is going to directly correlate with the content that was created today that came from Nelson because we want to hear, what have you learned today that you didn't know before? And that will be included in the follow-up email as well. And yeah, I just want to hand the floor over to you, Nelson, if you have any closing thoughts
Yeah.
or anything.
Appreciate it, Heather. I
Yeah.
would appreciate it if you don't mind, since you're the tech lady, the tech
Yeah.
guy, to actually save all the questions from the chat and to, I guess, send it to me on a PDF or a Word or whatever you want on an email, because I like to see them. Okay. I don't know. I think the reunion project. Do you guys have a forum or a way to
Yes,
exchange?
we do.
So
And
maybe we
yes.
can use that as a way for me to answer all the questions that were not unanswered today, because I like a challenge and see what else are being asked. I'm not a know-it-all, but I'll find out if I don't know it. So I like to address, I don't want anybody to walk away not feeling like they were taken care of. So if you could do that for me, that would be great.
Yeah, absolutely. There are so many channels that we can connect through the Reunion Project. We're on Facebook. We have a public group as well as a private group, which, you had shared that you have a few private Facebook groups for more direct conversations. So, perhaps that could be a way to facilitate that in a way that like everybody can see the conversations and the questions that are being asked and answered, and having an ongoing conversation. We want to keep it active and we want to continue to be in touch with one another. We're also on Instagram, Blue Sky. We have a general email address. We have a website. And as I said, we'll connect you directly with Nelson. But yes, absolutely. I think that's a perfect idea.
Yeah.
And we can just start like a conversation thread in there and continue it. Yeah, absolutely. I would love to do that.
Yeah, and I would really appreciate it if you guys, I think Larry's already a member, become a member of my post health group. It's actually not an online, not a Facebook. It's online. Nobody has to know your name or anything, because that really is, if you're a geek, if you really like, the latest of the data, that's where it is. That's what's happening. So it's post health. I send the instructions on the slides, and in that PDF, you're going to be able to subscribe. Because that really is. You can ask me 100 questions there. We're going to go on. We can go on all day there. And people are actually 1,500 people that have been surviving like all of us since 2002. So what's health at group.io. You'll see how to do so. So thank you so much. Stay healthy, guys. It's not an easy thing to be long-term survivor and aging. We're all happy that we're here, but at the same time, we're always wondering, what's going to happen next? What's the next health? But hey, resilience, that's what we're all about. Anyways, thank you so much and have a good evening. Bye bye.
Thank you. Thank you so much, Nelson. And thank you everyone for attending. We'll be in communication and continuing to send the love out to everybody, giving everybody hugs. Take care of yourself and do something nice for you today. And we will see you very, very soon. You all have a
Bye
nice
bye.
day. Bye.